Welcome again, everyone. I hope you're all ready for another fascinating session on NICU procedures. We'd like to invite the following people to help us with this session. Please welcome Dr. Ahmed Al-Mazmi, consultant neonatologist, Sheikh Shakbout Medical City, Abu Dhabi, and Dr. Akuma Oti Akuma, chair of neonatology, consultant neonatologist, Corniche Hospital, Abu Dhabi. Dear doctors, the session is yours.
Thank you. Okay, do we start? Yeah? Okay. Good morning, everyone, again. Please do have your seats. We have an exciting session before us that will look into more about NICU procedures. It gives me pleasure to invite our first speaker for this session, Dr. Natalie Rintol. Natalie is a professor of clinical pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She is also a medical co-director of the Special Delivery Unit Neonatal Service. It gives me pleasure to invite her to talk to us on this exciting topic, fetal therapy update. She will be talking about the fetal endoluminal tracheal occlusion and the renal anhydramnios fetal therapy. Please join me in welcoming Natalie.
Good morning. So, research and clinical boundaries have been challenged and crossed successfully, transforming fetal therapy from the theoretical to the routine. So if we think about it, our patients start here in utero. And when you think about what is a birth defect, what is a congenital anomaly, when does it start? When does it become set in stone that that is what is going to happen? Are there ways that we can intervene and change the trajectory of development? So today I'm going to briefly review the rationale for fetal intervention, and I'm going to discuss two important trials. The first one is the FETO trial, which is complete, and the second one is the RAF trial, which is ongoing. I have nothing to disclose. The Center for Fetal Diagnosis and Treatment is a busy fetal center. We've seen more than 20,000 patients. We have families from over 70 countries in the world, and we've performed over 2,000 fetal surgeries for congenital anomalies. Really, the premise for fetal intervention is that it's possible to alter the natural history of the disease and hopefully to improve outcome. So the first trial that I'll discuss is FETO, fetoscopic endoluminal tracheal occlusion for congenital diaphragmatic hernia, with the theory being here that an intervention can alter the course of pulmonary hypoplasia and hopefully lead to growth of lungs and improved outcomes. So I'll go back in time a little bit to tell you how we got there. So fetal surgery for CDH started almost 40 years ago. The first report was in the New England Journal in 1990. The team at that time tried to do an open fetal repair for a CDH, but when they pulled the liver down, the umbilical vessels kinked and the patient died. After this, this was completely abandoned around the world. However, three key developments came from this experience. The first was we now have some prenatal measures of severity. It forced the teams to look at alternative physiologic strategies to enlarge the hypoplastic lungs, and also to look at less invasive endoscopic techniques. We now use ultrasound to look at the prenatal status of CDH and to assess severity. And what's fascinating about the liver herniation piece, this actually was discovered and noted by a bedside nurse at the University of California. She noted that kids with liver herniation often died, and in fact, that's one of our most important prognostic variables at this point. The other factor that we use is lung to head ratio. So that's measured at the 4-chamber view of the heart, a measure of the contralateral lung divided by the head circumference. Now this tends to change over time and it can appear like it's growing. So most recently, we now have this observed over expected LHR, and this tries to make it a little bit more constant over the time of gestation. And recently now we also have the ability to measure total lung volume with MRI. We consider severe pulmonary hypoplasia to be at an O to E LHR less than 25%, where the chance of survival is less than 25%. So now to take a quick look at some of the alternative physiologic strategies and endoscopic techniques. Around about this time, it was also noted that babies with congenital high airway obstruction, notably from laryngeal atresia, also had very large echogenic lungs. Sometimes their diaphragms were flat or inverted, and the airways distal to the obstruction were quite dilated. So knowing this, the teams went into the lab and they did fetal lamb models where they did prenatal tracheal occlusion to obstruct the normal egress of lung fluid and found that this increased lung tissue stretch, increased cell proliferation, and accelerated lung growth. However, if that occlusion wasn't released prior to delivery, those lambs had trouble. So what it appeared was that the type 2 pneumocytes were decreased during that occlusion. So then they got into this plug-unplug sequence where they would release the occlusion to normalize the number of type 2 pneumocytes that make the surfactant. The European Fetal Task Force published a large feasibility study in 2009, and they noted an increase in survival in both left and right CDH. So these are human babies. This was very important work, although some people said it wasn't randomized, it was encouraging, it was reassuring, but it wasn't scientifically sound. So Jan de Prest, a very famous obstetrician from Belgium, put together the largest randomized controlled trial of fetal therapy to date in humans. This is the landmark trial that was published in the New England Journal in 2021, the randomized trial of fetal surgery for severe left CDH, the total trial. This was an open label trial done at 10 centers. Patients were randomly assigned to either go through feto or expectant care. This was for severe isolated left CDH, babies or fetuses at 27 to 29 weeks of gestation with an O to E LHR less than 25%. The balloon was inserted at 27 to 29 and 6/7 weeks gestation. So this is what the balloon looked like. It almost looks like a small grain of rice when it's deflated, very tiny. And this is Holly Hedrick in the middle. You've heard her speak at this conference in previous years. So this is her, she's our fetal surgeon, placing this tiny balloon endoscopically. So MFM uses an ultrasound to look at the baby, and then she'll go in with a fetoscope and intubate the baby with that scope, deploy the balloon above the carina, and then it gets filled with 0.6 mLs of saline. And oftentimes within 48 hours, we can see a change in the echogenicity of the lungs. The balloon is removed at 34 to 34 and 6/7 weeks. The primary outcome of this trial was survival to discharge from the NICU. And here are the results. So you can see, let me see if I can get this to work. So survival to discharge was increased from 15% in the expectant group to 40%. And this survival was maintained at 6 months. In addition, the preterm, pre-labor membrane rupture was also increased 4.5 times in the fetal group, and the risk of preterm birth was 2.5 times as high in the fetal group. During this time, the North American centers were also working on feto. That was a regulatory rule in North America. We had to do 10 fetal balloon insertions in order to join the trial. So there was data acquired in the NAFNet, and Tony Johnson, he's an OB MFM in Texas, presented this at the Society of Maternal Fetal Medicine, the conference just this past February. And what the group in North America showed was that there was no difference in survival. And you may wonder what to do with this, but remember it was the expectant group in the feto, the total trial, had a survival of 15%. And many centers in North America have survival of 70 to 80% in that group. I mean, it's a long haul, lots of morbidity, ECMO, they're in a hospital a long time, but the survival's much higher. So we did not see a difference in survival, but when we looked at our first 10 patients, we did see a lower rate of ECMO, and this was one of our most interesting findings, was that we had about 60% of these high-risk babies going home on pulmonary hypertension medication, but the feto babies, none of them went home on PH meds. We also did find less respiratory supported discharge and a decreased length of stay. Another group from Texas reported their experience as well. Feto was independently associated with increased resolution of pulmonary hypertension by 1 year of age. So one thing, this is a picture of the, remember I talked about the critical knowledge screens that we have. This is one of our screens that we have up in the OR. One of our biggest concerns, as soon as that balloon goes in, that 27 to 29 weeks, is that that mom is out in the community and her fetus has a balloon in the airway. So we are all hands on deck, until the balloon comes out. If the mom's coming in cramping or she's got a little malaise, we all come in. And if she's okay, then we go home. So this is a very intense situation for us when a baby has a balloon in place. If she comes in and it looks like she's going to deliver, we've got a full protocol, full team. If there's a balloon in place, she may undergo an exit, a modified C-section, and if things are going quickly, a vaginal delivery. But we have ENT and Holly Hedrick and some of the other surgeons there to try to get that balloon out. If the balloon is removed and the baby delivers within 48 hours, we have a whole other series of protocols based on our experience because the secretions are really thick, like plugs, like concrete, after there's been a tracheal occlusion. So we have, a full algorithm based on our work with Belgium and based on what we've seen. So we do give surfactant to try to clear out the secretions, and they do go on the oscillator. ENT is there. We're in the OR trying to clear out the airway. So one of our biggest problems with feto is, being nervous about that balloon being in place, having a team to go in. Are we able to puncture it, obtain it fetoscopically? Do they need to deliver by exit? How can we make that transition safe for that baby? And we do still have equipoise, but we are seeing decreased pulmonary hypertension and the lungs are a bit bigger. So we're We are offering Fido for the most severe, and we're learning and we're following them very carefully. But our biggest concern is that balloon. So Fido of the future is this smart tracheal occlusion balloon. And what's fascinating about it is that there's a magnetic valve in the balloon, and it deflates when it's positioned near a strong magnetic field. So Jan Deprest and his colleagues in Paris are doing a single-arm interventional feasibility study right now to look at the efficacy of removal with this smart tracheal occlusion balloon. The primary endpoint is successful deflation. The secondary objective is the safety of the balloon, and the secondary neonatal endpoint is survival to discharge. And this is just so fascinating. Jan shared this video with me so I could share it with you today. So what they do is they have the mother come in and she walks around the MRI scanner, just walks around very close, goes all around. They do an ultrasound before she does this to make sure the balloon is in place. They walk her around. Doesn't take very long at all. And then at this point, the balloon should be deflated. And then there's that natural egress of fluid from the trachea, so the baby expels it in the airway, and then they'll do an ultrasound to prove that it's gone. So this is the future. I think that if this truly does decrease ECMO and decrease pulmonary hypertension and it's easy to get the balloon out, more to come. I mean, this is very exciting. Okay, so now we'll switch and we'll talk about the renal anhydramnios fetal therapy trial. And this trial is ongoing. And what's interesting about this is it's similar to the Fido trial in that the goal is to have the lungs grow. So it has nothing to do with the kidneys. It's really similar in that the lungs, it's all about the lungs. However, it's really pulmonary palliation as a bridge to renal replacement therapy and ultimately renal transplant. Early pregnancy renal anhydramnios, as evidenced by no amniotic fluid by 22 weeks, can be caused by absence of the kidneys or non-functioning kidneys, like multicystic dysplastic kidneys, lower urinary tract obstruction, those types of processes, those two things. Untreated early renal anhydramnios is universally fatal, lethal pulmonary hypoplasia, neonatal demise. It appears to be that the duration of anhydramnios worsens the degree of pulmonary hypoplasia, but there's an inflection point around about 22 weeks. Fetal urine is the major component of amniotic fluid, and even after 20 weeks, the fetus is making a lot of urine. Urine is very important to maintain lung distension, and it also contains proline, which is necessary for lung maturation and formation of collagen and mesenchyme. This study was a case report from 2004, showed a monoamniotic twin gestation where one of the twins had absence of the kidneys, but delivered with normal pulmonary function. So that was, very intriguing about this whole idea that if you have normal amniotic fluid, your lungs grow. But it was a case report very early on. And then I don't know if you've heard of this story. This is a very high-profile case that we talk a lot about in the US. This woman was a Republican congresswoman when she became pregnant with her first child. On her anatomy scan at 23 weeks, it was noted that the baby fetus had no kidneys, and she was told it was going to be lethal. So she went to the media to get help, and she received information and ideas from families all around the world. And one physician at Johns Hopkins agreed to do serial amnio infusions with saline. The baby delivered at 29 weeks with no pulmonary issues and was subsequently discharged home about a month later. This little one underwent dialysis for 2 years and then had a transplant from her father. So this is very much in our media. Families know about this case, they know about this story. Very high profile situation. This is her a year later. There's always photos of her. Here she is in a budget hearing in the Capitol in 2017 on her mom's lap. Dr. Beanstalk is the physician, Jessica Beanstalk is the physician that did this in uterine intervention. She published this work in Obstetrics and Gynecology, and she said that by restoring the amniotic fluid, it allowed repressurization of the fetal tracheobronchial tree to promote normal lung growth. There have been several other case reports also showing that the lungs will grow if there's normal amniotic fluid. So then there was a summit because this was out in the media. There were several case reports. Families were coming to fetal centers asking about it. And there was a large summit to discuss the ethical considerations regarding amnio infusions. And I give credit to these colleagues at Johns Hopkins for really taking this on, pushing the boulder up the hill, people have said. They really got this trial off the ground. So this is the RAFT trial, a multi-center trial. There's 9 centers in the US currently. The original trial looked at bilateral renal agenesis in one group and early renal failure in the other group. Anhydramnios was diagnosed before 22 weeks. Enrollment was by 26 weeks, and the first amnio infusion needed to happen by 26 weeks. Fetuses needed to have a normal karyotype and a microarray. This is an interventional trial, non-randomized. The idea was to have 70 participants, 35 in the renal agenesis group, 35 in the fetal renal failure group. The primary outcome was the proportion of newborns surviving to successful dialysis, and this was defined as use of a dialysis catheter for greater than or equal to 14 continuous days. After the first 20 babies were enrolled in the bilateral renal agenesis arm, the DSMB did an interim analysis and stopped that arm of the trial. This was just presented at that SMFM conference that I mentioned in February, a couple months ago. The reason for this is that they said the primary efficacy was met. More than 75% survived. However, they were very concerned that the initial survival was 80%, but only a third of them survived a hospital discharge, and many of them had strokes. And in fact, there are 17 survivors right now, of the 17 that made it out, there's actually only 2 survivors currently waiting for kidney transplant. With regard to the strokes, this was noted by Dr. Lammert, one of the neurologists working with the Hopkins team. High rate of strokes, but a very novel pattern of injury with no underlying cause identified. She's calling them quadrantal strokes. They're occurring unilaterally, spanning multiple lobes, and they're not confined to one arterial distribution. So they're very interesting. So we still need to learn more about this. However, the intervention works. These babies did survive without lethal pulmonary hypoplasia. So what's happening to us now is that families want it. And families are coming, asking for it. So this has become an incredibly difficult area of work where we've had multiple meetings over the last few months to try to figure out what to do. We as a center have said we're loyal to the trial. The arm has been shut down. We're not doing them. But we are getting calls all the time for babies who've gone through this amnio infusion process at other centers who are now coming to us for dialysis and transplant. Some people say, is it that bad? Is it like the hypoplasts and the Norwoods of 40 years ago? You know, and some of you might even be thinking, is it like the 22-weekers that we talked about yesterday? Is it that wrong? So this is a big area of discussion right now. So currently, the RAFT trial that's ongoing, recruitment is only for the non-bilateral renal agenesis, the fetal renal failure kids. The patients will undergo amnio infusions with isotonic fluid every 2 to 12 days, and the latest infusions start at that 26-week mark versus the expectant group. So more to come on this. So thanks so much. Thank you.
Good morning, everybody. Thank you, Dr. Ventrell, for such an illustrative talk. I have to echo the fear that we spoke about when mothers have a fetal-sclerotic procedure where there are loss to the community, and we as trainees have to be prepared for when they come back and show up with a baby that has a fetal done to them. But moving on, it is my pleasure to introduce our next speaker, Dr. Matthew Gillespie. Dr. Gillespie is an attending cardiologist at the Cardiac Center and the medical director of the Cardiac Catheterization Lab of Children's Hospital of Philadelphia. His expertise is in interventional cardiology and transcatheter placement of heart disease. And he's going to talk to us about transcatheter closure of the PDA. So join me in welcoming Dr. Matt Gillespie.
Great.
Hello, my name is Matt Gillespie. I am the Director of Interventional Cardiology at Children's Hospital of Philadelphia. I'd like to thank the organizers for giving me a chance to talk to you today. And we're going to be discussing transcatheter closure of the patent ductus arteriosus in premature infants, technical progress, and meets clinical ambivalence. These are my disclosures. Important, probably most importantly, Abbott is the manufacturer of the device that we use most commonly to close PDAs, called Piccolo, and I'm a consultant and proctor for them. I also work on their medical advisory board. And up front, I'd like to acknowledge Sham Sathanandam, Bill Bennett, and Evan Zahn, all of whom have been on this PDA closure journey with me and others internationally. Now, and they've been kind enough to educate me and to share some slides with me as well. So up front, when you're talking about transcatheter PDA closure in extremely low birth weight infants, if you're going to consider this for your program or start potentially considering this or applying this to your patients, it's key from an interventional cardiology standpoint that you need to have a partnership, and that partnership has to be between neonatology and interventional cardiology. And that sounds very simple and very logical, but this is actually easier said than done. And I think this is the most interesting piece about catheter-based PDA closure in these babies. We'll talk a little bit about the technical piece, but really it's this need to sort of talk to each other and understand where the two disparate groups are coming from has really been one of the most interesting things over the last really decade now, as we've been on this little bit of adventure. And why can it be challenging? And the reason is that there really is no consensus, and that's the bottom line from this talk. There's no consensus about what the best management is for the PDA in these small babies. And in the if you don't have a consensus, it's really hard to move forward with a new technology. So there absolutely is a need for consensus, because on the one side, you have the neonatologist, and I am always impressed by my neonatology colleagues, and in a lot of ways, what you do as a neonatologist is so far beyond me. It's that minute to minute, second to second, incredibly detailed attention that every individual patient gets in the NICU that allows them to grow and to heal and to thrive is nothing short of heroic. So the neonatologists own these patients. They own them minute by minute, and it tends to be a very detailed-oriented group of people that doesn't miss anything. And if you're going to come in and potentially apply a therapy to these patients, what you're going to hear is, well, where is their data? Where's the data that closing the PDA is actually going to help anyone? And then on the other side of the bridge here, you have the interventional cardiologist, talented in their own way, maybe, but maybe not as detail-oriented as the neonatologist. And essentially, our question is, what's with all the questions? We can do this. Why don't we just go ahead and do this? And it really, being silly, but there is this divide there that we have to come together. Otherwise, there's never going to be progress. And so how did it get to this point? And I think that my experience over the last 20 years is really reflective of everybody who's been involved in interventional cardiology and in neonatology over the last 20 years. So if you go back to the late 90s, early 2000s, when I was in residency here at CHOP, honestly, every PDA got ligated. Everybody got 2 to 3 doses of Indocin. If it didn't work, if there's any suggestion it was hemodynamically significant or not, there was a surgical PDA ligation. So this, through my residency and through my early cardiology training, was ingrained in me that PDAs are bad and PDAs need to be closed. Well, all of this changed somewhere around 2007, and it went from we treat every baby that has a PDA pretty aggressively, first with medicines and then medical failure with surgery. And then in 2007, seemingly and unbeknownst to me and most people in the interventional community, things changed abruptly. And I blame my friend Ron Kleiman for this. I think it's this paper really that called out surgical closure of PDA as being significantly associated with development of chronic lung disease, independent of anything else associated with prematurity. So really calling out invasive PDA closure, which was surgery at that time, as an independent risk factor for bad outcomes. And there were other papers, this paper by Dr. Cabra suggested that PDA ligation independently associated with neurosensory impairment and chronic lung disease. Now, these studies, unlike a lot of pediatric studies, have an appropriate number of patients enrolled typically, so you can reach statistical significance with these NICU populations in a way that's not as always easy to do in fields like congenital heart disease, where the patient volumes tend to be lower. So these are really well developed and executed studies, and pointing against surgical PDA ligation. And then to take it one step further, Bill Bennett's looked at all the randomized controlled trials of PDA management over decades. And essentially, what he came back with says, hey, you should leave this alone. There is no evidence that there's any proof at all that closing the PDA, either medically, surgically, or otherwise, is actually good for the babies. And this was really a sea change. And from 2007 to present, there has been this overall belief that PDA closure, really, there's no proof that it's beneficial, and in fact, it may be harmful. So, and this is Bill speaking in Portuguese at a meeting in Brazil. So this was a global phenomenon. We went from again, my early experience as a resident, as a trainee, that we're closing all of them, to this sort of current state of ambivalence where it's, we know that PDAs are bad, as Bill would say. We know that preterm babies, it's associated with a variety of bad outcomes. We know that medical and surgical treatments can work, but the critical question is out there is, does that reduce the risk of any bad outcome? And Bill is fair enough in asking that. And that very question really was part of this swing away from the late 90s, early 2000s, treat everyone, to really, we're not treating anyone. I mean, it's a bit of an exaggeration, but really reluctance towards treatment. So, well, how about, that's from the neonatologist perspective. Well, how about from an interventional cardiologist perspective? A simple creature relative to the NICU doctors, and more simple plumbers. And we look at things very simply from a hemodynamic standpoint. And I think the best way to illustrate that is just to take a recent case. And we close a lot of these PDAs, so we see a lot of it. And this is a very typical example. This patient, 6 weeks old, X27-week premature baby, born at 750 grams, comes in to the cath lab for PDA closure at a weight of 1 kilogram. And this is just a diagram denoting the hemodynamics. And what you'll notice is that the branch pulmonary artery, the main pulmonary artery pressures are basically systemic. It should be about a quarter of systemic. And the oxygen saturation in the branch pulmonary arteries is the same as it is in the aorta. And that yields a massive, massive, massive left to right shunt, which is a massive volume load on the lungs and a massive volume load on the left heart. And from a cardiologist standpoint, this is a patient in heart failure. May be compensated, but is absolutely a patient in heart failure. And if this is a VSD or any other shunt lesion, it would be immediately corrected because this is not a situation that's compatible with a long life. So this hemodynamic situation, forget that it's a premature baby, is heart failure. So what does this look like? Angiographically, here's what you see. And if I pause this little angiogram, you'll see that the PDA is the bridging vessel between the aorta here posteriorly, the pulmonary artery anteriorly, and this is the PDA. And this is very typical. The PDA is the same size as the aorta. It's gigantic. It is not something that's small. So this is what it looks like from space, okay? It's a Category 5 hurricane inside that little chest. It's a cyclone. This is a really unstable situation purely from a hemodynamic standpoint. So, incidentally, our echocardiograms, if you look at the 3 echoes that this baby had over the last 6 weeks, at most, the echocardiographers are saying, oh, it's a moderate PDA, maybe it measures 2 to 3 millimeters in diameter, and that's all you get. You don't get the description of heart failure. You say, oh, yeah, it's a moderate PDA. So it reinforces this idea that maybe, it's moderate, maybe we can sort of manage through this. And we see patients like this all the time coming to the cath lab that sit for weeks in this situation. And it's really hard to understand. So from an interventional cardiology standpoint, like that lesion should be taken care of to the benefit of the heart and the lungs. Well, why do we care about volume and pressure load in the lungs? This is not a new issue. We know that this is very bad for the lungs. And there have been animal studies dating back to the late 80s, early 90s, like this one here, that show that the premature lungs in a lamb and in a newborn baby are maximally recruited. They have no regulatory capacity. So when you go ahead and flood them with pressure and you flood them with increased volume and increased pressure, what happens is you get interstitial edema. You just get capillary leak into the interstitium. What does that look like from a lymphatic standpoint? There are lymphatic models in sheep which show that if you volume load and pressure load the lungs and then you image the lymphatics are engorged because that hemodynamic, that hydrostatic load pushes fluid into the interstitium. The interstitial fluid is reabsorbed by lymphatics, and you get this engorged lymphatic interstitial edema picture. Okay, so this is from my colleague Yoav Dori, who does a lot of lymphatic imaging and intervention. And what you're looking at here is a lymphatic angiogram. And on the left, the patient is on a positive pressure ventilation. And with the high intrathoracic pressure, you see the contrast is hung up. So when the baby's on the ventilator at high mean airway pressures, the lymphatic drainage coming out of the thoracic duct is attenuated. So all that extra lung fluid is sitting around in the interstitium because it can't drain through the thoracic duct into the great veins because of the high intrathoracic pressure. And when you disconnect them from the ventilator, I don't know if it projects well, but what you see is you get an immediate flow of lymphatic fluid marked by this contrast into the innominate vein. So the thoracic duct begins to decompress, lymphatic flow starts to flow. So in summary, We know that the pulmonary vasculature in premature babies is very, very sensitive to volume and pressure loading. This is not a new phenomenon. This is something that's well understood by everybody who's been involved in the care of premature babies for the past 40 years. We also know that premature PDAs represent a massive volume and pressure load that contribute to worse interstitial edema. Lung edema confounds all the ventilatory strategies, necessitating higher mean airway pressures, higher FO2, which then leads to more lung edema and lung damage. So from a cardiology standpoint, if you're in this situation where you're trying to preserve the lungs and trying to manage them and trying to keep your airway pressure down, your FiO2 down, why would you leave them with a massive, massive left to right shunt and volume load, even for a day? From a cardiology standpoint, it does not make sense. And then further, PDA sits right in the middle, again, from a cardiologist standpoint, of this NICU alphabet soup. And it's a problem in and of itself, but it also exacerbates things like interventricular hemorrhage, retinopathy of prematurity, BPD, necrotizing enterocolitis, on and on and on. So it not only is a problem in and of itself, but it actually adversely affects these other issues that are going on. So if that's the case, and there's a safe and effective way to get rid of the PDA, it seems that we should be doing that. So, well, what do we know about safety in closure of premature babies? Now, about, I guess, now 5, 6, 7 years ago, when we really started venturing into this, we didn't have a lot of data to even say that doing this procedure was safe. But since then, we've had the Piccolo trial results, which have been published. There's now 3-year results, which was remarkable. And you can look at those. I'm not going to bore you with the results. I'll just say that there were 200 patients enrolled in that trial. 100 of them were less than 1 kilo at the time of the procedure, and the procedural morbidity and mortality rates were exceptionally low. There's, in addition to the Piccolo results, there's a published single center experience coming from everywhere. At large volume centers like we have CHOP, we've treated approximately 300 patients less than 2 kilos over the last 5 to 6 years. And honestly, I have not been part of a procedural rollout in a high-risk group of patients where I've had zero procedural mortality, minimal morbidity, and we've actually seen promising clinical benefit, which we're trying to collect that data now. And so from a technical standpoint, I think what we've demonstrated now here at our center and at other centers like ours around the globe, that you can safely and effectively close the the PDA in the premature baby, even in the sub 1 kilo range, very effectively and very safely. So what does that look like? This is another example. It's a 750-gram X24-week premature infant that comes into the cath lab. On the left-hand panel there, you see a LAO cranial view, and on the right-hand side, you see the lateral view of the ductus. And this is just a 4 French catheter that's advanced from the femoral vein that comes up through the heart, right ventricle, pulmonary artery across the PDA, and into the descending aorta. And as is the case with a lot of these babies, sorry, let me go back. The PDA looks to be about the size of the aorta. It's a massive left to right shunt. This is what it looks like. This is a 4-2 Piccolo device delivered through its delivery catheter. It's made of nitinol. It has 3 lobes on it. You can see it. The nitinol allows it to be compressed into that 4 French catheter. And as you withdraw the catheter, the device expands and locks into position within the ductus itself. You can take a little sighting angiogram to show that the left pulmonary artery is not obstructed. And if you take a look by echo, which I'll show you in a second, then it's a matter of just simply detaching it from its floppy delivery cord, which is recorded here. You'll see in a second that that device separates away from the delivery system. Then afterwards, you take a little picture. You can show that the Piccolo device is completely inside the ductus. And when you look at this by echo, on the left pulmonary artery is wide open. And on the right-hand side, you see that the aorta is wide open at all. So what you've done is you've closed the PDA, and you've done it without impinging on any of the important adjacent blood vessels. that whole procedure, once drapes are on and lines are out, can be as quick as 15 minutes at our center. And there's a lot of buildup around that, getting the neonatology team to help with transport up and maintaining body temperatures and socializing the anesthesiologist and getting them on board with how best to manage these babies. There's a bit of a learning curve with that. And that's all part of the procedure. But once that was established and people became comfortable with it, we really have been able to do this very efficiently. And I think our experience mirrors that of a lot of centers around the world now. In fact, a lot of folks are pushing to try to do this at the bedside using primarily echo guidance. I think that there's a space for that, but right now this is our practice, is to do this in the cath lab, and it's been working very well for us. And again, we took this baby, out of this sort of tempest situation and alleviated the shunt, which I think is probably going to be bad. So yes, so consensus is a challenge. And what's missing from this equation is where we need proof that doing this procedure is actually going to help the babies in the longer term. And I think we're sort of evolving to a point now where this is going to where we're going to start getting answers in the years ahead. And importantly, I'll say this: in the United States, Carl Backus and colleagues are running, and Darren Berman together are running the pivotal trial, which is a prospective multi-center comparison of PDA closure using the Piccolo device in the cath lab versus standard medical management. And there's going to be pretty robust and long-term follow-up to actually compare these babies to a control group to see if we're actually making a positive difference to match the hemodynamic improvements that we're seeing with the acute procedure. So I think we are at an inflection point. I think if you look at what we have now, the interventional cardiology community in combination with the industry has really worked out this sort of procedural technical part of this to the point now where closing PDAs, even in the smallest babies, has become routine at a lot of centers. We even have an FDA-approved device, so the FDA is even on board with this, and it's now been proven safe, efficient, and efficacious with now 3-year data out there, which is very promising. And I would implore my neonatology friends to stop looking backwards at the old data saying there's no proof that closing the PDA is good, because I would submit to you, and the interventional colleagues would submit to you, that the way you were closing the PDA was pretty toxic, both the medicines that you're using historically, and surgery is like a small car accident. A thoracotomy in a fragile baby like that can take a lot of recovery, and I'm not surprised that it carries with it some maybe long-term morbidity. So let's now start to focus on how these novel therapies, which we're proving can be done safely and effectively, let's start applying them to patients in an organized way so we can understand who's going to benefit the best from these. So in summary, nothing good comes from a big PDA, an extremely small baby. From a cardiology standpoint, we have an FDA-approved device, and we're now proven that we can do this safely and effectively. We can eliminate that shunt, eliminate that volume and pressure load on the lungs. The NICU data historically is so impressive, but it really has not led you to any sort of settled law about the best way to manage it. And I think looking forward with this newer technology that definitively closes the device, PDA safely and effectively in the cath lab, I think we're entering into a new era. And now we're entering into the point where the pivotal trial is going to give us data, and we're really going to be able to sort out the patients that are going to benefit the most from this procedure. So with that, I'm going to stop and once again acknowledge Sham, Bill, and Evan for sharing slides with me and for educating me along the way. Again, thank you to organizers for giving me a chance. Sorry I can't be there in person. And just say thank you and goodbye.
That was an exciting topic again. Please do keep your questions. We will take them at the end of the whole session. It gives me pleasure then to introduce our third speaker, Our third speaker is Dr. Saeed Ali Raza, one of our colleagues here in the UAE. He trained in the UK and practiced there also before coming to the UAE in 2013. Presently, Saeed is one of the consultant neonatologists who work at the SSMC hospital. He will be talking to us on a topic titled Echo by the Neonatologist. Is it a friend or is it a foe? Do welcome Saeed to the pen, please.
Thank you very much, Dr. Junaid and Dr. Ayman, for giving me this opportunity to share my experience of neonatal echocardiogram in this country. And then I leave you to decide, is it a friend or a foe? The aim of my talk is really to understand the role of NOP or neonatologists doing echocardiograms. And the objectives are to show the practice indications of NOP in my unit and to demonstrate the NOP implementation through various case discussions. And then we can evaluate NOP performance by going through my audit results. My physicians have been performing echo in a neonatal unit for the last three to four decades, since 1990s. But over the last couple of decades, its use has increased significantly, and it has resulted in improved cardiorespiratory care in newborn. This slide is just a couple of slides are about my NOP approach. I was trained as a neonatologist with pediatric cardiology in trust, and when I joined my unit here, then I started providing this service of echocardiography in collaboration with pediatric cardiology team at the referral unit. And interesting, you can see this machine is quite old machine. That's the machine which I have in the beginning and was recording the echoes on the video cassettes. And then luckily we have a new machine able to store the images and then download on a CD can be sent to the cardiology team for review. And now we can download our images in the Cerner system and they can review the images directly. At the moment, currently, we have got pediatric cardiologists in our in-house, and I'm still providing this service. Whenever I am asked to do an echocardiogram, then I usually do a detailed echo, going through the subcostal view, apical, and then parasternal short and long axis view, and then looking at the arch. There are three main groups of targeted neonatal echocardiograms, main group of indications. The first big group of indication is hemodynamic assessment, most of the time doing use of targeted neonatal echocardiograms. I also use it for ruling out congenital heart disease, and the third major group is for PDA management in our preterm patient. Coming to the hemodynamic assessment, we all see persistent pulmonary hypertension is a quite frequent issue in our level 3 neonatal unit. And really, it is quite difficult for a neonatologist to differentiate it from cyanotic congenital heart disease clinically. So the targeted neonatal echocardiogram can provide, can rule out cyanotic congenital heart disease, and the physician can focus on management of persistent pulmonary hypertension. And similarly, in neonatal shock or hypotension, my colleague Monica was talking about this, that there is an inadequate end organ perfusion, as we see in case of sepsis or in necrotizing enterocolitis or in post-PDA ligation. And the targeted or untargeted echocardiogram can give us information about the heart functions, the volume loading, and cardiac output. With these pieces of information, we can rationalize the treatment. And then the follow-up echo can give us the opportunity to look at the response to treatment as well. Now I'm going to go through few examples of hemodynamic assessment. For example, this one was a term baby who was admitted with respiratory distress and cyanosis, and a routine sort of suspected sepsis treated with antibiotic after doing first after doing some septic workup. But if you see, this patient has got a chest X-ray which is not showing significant pulmonary pathology, but was on mechanical ventilation, quite high requirement, and then he was hypotensive as well and was on 2 inotropic sports. So we decided to do an echocardiogram in this patient. And if you see this echocardiogram, it's quite easily showing this is a subcostal view, and which is showing the 4 chambers as well. And now you can see that really the walls are not moving at all. Yeah, so that was quite straightforward thing. So in such a patient, the issue is going on the cardiac contractility, and we really, if you see this one, is after treating with, so the patient was started dobutamine apart from other ongoing treatment, and within 24 hours he responded very well, and we were able to discharge these patients within a week with no any other issue. Coming to the second example, for example, we see in our neonatal unit quite frequently coming patient with hypoxic ischemic encephalopathy, and they need total body cooling. And they required intubation and mechanical ventilation sometime as well, but in sick patient there can be a problem with the oxygenations. And in such a situation, really, if you see this patient, again, chest X-ray, no significant pulmonary pathology apparently, but we decided to do an echocardiogram at midnight because there was problem with oxygenation and has been done quite a lot in terms of mechanical ventilation sports. So the echocardiogram was done in this patient, and this is quite obvious. If you see this one, again, Monica was talking about the IVC diameter and all these things, which is quite helpful. But this is a subcostal view, and you can see this IVC is draining into the right atrium. And normally you expect that this IVC should collapse as well, which was not in this case. So it was staying patent all through the respiratory cycle. But if you move to the next video clip, then you can see this is again a subcostal view, and you can see this interatrial septum and the 2 atria, right and the left one. And there is a bidirectional flow, which is indicative of increased pressure in the right atria. And when you move to the next clip, this is apical view, and patient has apical view, and there is a good going moderate to severe tricuspid regurgitations, which is indicative of increased right ventricular pressure, and the right ventricular pressure is indicative of pulmonary pressure. And you can see the maximum velocity as well on the Doppler, which is helping us to calculate the pulmonary pressure by looking at the pressure gradient. So in this patient, again, treatment was rationalized with initial inotropic sports to increase the systemic pressure, to reverse the shunt with dopamine and epinephrine. Again, dopamine low dose. In moderate dose, it has got a beta effect, and epinephrine again in a low dose, which is less than 0.1 or up to 0.1, which causes more inotropic and vasodilatory effect. Patient not responding to, then patient was moved to inhaled nitric oxide was started. An interesting thing is we were able to discharge this patient with normal neurological examination, and patient seems to be doing fine after discharge. Another example is about a 34-weeker who was about 2 kg, and then he was also admitted with suspected sepsis, which settled down and antibiotics stopped. But on day 4, this patient became unwell with more tachypnea, desaturations, and mottled as well. Again, it was midnight. We had a septic workup and started an IV antibiotic and some respiratory support as well. And the chest X-ray, there wasn't much really, if you see any significant pulmonary pathology. And the inflammatory markers were also normal. So we decided to look at to do the echocardiogram. And if you see, this is again a subcostal view, which is showing the 2 atria and the interatrial septum. And again, this one is showing a significant moderate to severe tricuspid regurgitation, and which can help us to calculate the pulmonary pressure, looking at the right ventricular pressure, and you can see the maximum velocity of the pulse wave Doppler, which is significant, around about 3 to 4. And again, another sign of pulmonary hypertension is if you look at this video clip, you can see clearly this is still a subcostal view, and the interventricular septum is pushed to the left. So that's indicative of increased right ventricular pressure. And even if you look at this one, the right ventricle is quite dilated related to the increased right ventricular pressure and then related to the ventricular pressure, pulmonary pressure. So at this stage, this patient was discussed with cardiologists. They agreed with that finding, and then they asked us to transfer this patient to the pediatric cardiac ICU. But there was no bed available, so the patient was managed in our unit following the line of persistent pulmonary hypertension, being quite sick, started central lines, intubation, mechanical ventilation oscillator, and then he was started also epinephrine as well, and the milrinone and inhaled nitric oxide. Most of the time we are using milrinone as a pulmonary vasodilator, but yes, it has got inotropic effect and the pulmonary and the peripheral vasodilatation as well. But in this patient, mainly it was used because to help to bring down the pulmonary pressure. And if you see after, I think it's just after 3 days, we have this echocardiogram, and you see it, in this view, it's subcostal, but showing all 4 chambers, and you can see the right ventricle really dilatation has gone completely, and patient has responded very well to the treatment. And we were able to discharge this patient on a pulmonary vasodilator in 3 weeks' time with normal systemic examinations. And then this patient has got a cardiology clinic follow-up appointment and seems to be doing fine. And if we look at our patient with persistent pulmonary hypertension, and that data was collected over a period of 5 years from 2013 to 2016, we have about 18 patients, and 6 patients were related to congenital diaphragmatic hernia, 1/3 were related to the prematurity group, and almost 40% were related to term or near term, and they have a meconium aspiration, hypoxic ischemic encephalopathy, and sepsis. And you can see they has been quite sick, having various types of mechanical ventilation requirement, and even they need inhaled nitric oxide. And hemodynamically, some of them were unstable, and we define instability if they have been on 2 inotropic sport or more. Coming to the next group, the congenital heart disease one, we do screen for congenital heart disease if the patient has got a heart murmur, or if he has failed congenital heart disease screening test, or if there is a family history of congenital heart disease, especially the left-sided lesion, like aortic stenosis or coarctation of aorta, or if the patient has got a dysmorphic feature and we are suspecting a genetic diagnosis. We also have a routine practice to do echocardiogram in newborn in surgical cases as well. And then again, going through few cases, how we have been making diagnosis in this patient. But this is a term baby who had male normal vaginal delivery but has got dysmorphic features, and suspected diagnosis of Down syndrome, mother multigravida, and she was 39 years old, and the baby was admitted with respiratory distress. Considering dysmorphic features, genetic investigations, and the echocardiograms were done. And you can see it's not very difficult to diagnose. It's a subcostal view, and then patient has got a big AV septal defect, and there is a single AV valve. So the diagnosis in this echo video clip is that patient has got a complete AV septal defect and a single AV valve as well. And when we move to the next video clip, it's again showing the same kind of finding, that you can see a single AV valve, a big VSD, which is part of the AV septal defect, and then the aorta coming out of the right ventricle. But interestingly, when we did the suprasternal view in this patient, that this patient has got a coarctation of aorta as well. This is a suprasternal aortic arch view, and you can see there is narrowing at this point. So at this point, following this diagnosis, we refer the patient to we started prostate first, and then we refer the patient to the cardiology unit, who reviewed the echocardiogram and agreed with the diagnosis, and the patient was shifted to the pediatric cardiac ICU, where they did the CT angiogram, which shows the diagnosis of aortic arch hypoplasia, and then this patient went abroad for corrective surgery. Second case in this is a term baby admitted with respiratory distress, and the chest X-ray was done for respiratory distress, which revealed apex on the right side. And when we did an echocardiogram in this patient, you can see has got a This is subcostal view, situs, and that's the aorta. You can see this one. And when we still in the subcostal view, you can see the apex is directed to the right rather than normal to the left. And then morphologically, right ventricle is situated on the left side with right atrium draining into the ventricles. And usually the valves moves along with the ventricles. So this is our tricuspid valve as well. And moving to the next clip, if you see, that's just showing that the outflow tract of the morphologically right ventricle, which is present on the left side. And if you look at the next clip, that's just showing the morphologically left ventricle situated on the right. And the difference between on the morphology of the right and the left ventricle is, in left ventricle, the interventricular septal valve is quite smooth, whereas in the morphologically right ventricle, the interventricular septal valve is has got a lot of muscles and roughened as well. And in this diagram, you can see a video clip. You can see this is the mitral valve, left ventricle, and the aorta coming out from it. So this patient was really having a diagnosis of situs inversus with mirror image dextrocardia and the right-sided aortic arch. So he does not need any intervention, and so was discharged from our unit, and then was seen by a cardiologist once to confirm the diagnosis. Moving to the next third case, that the baby from postnatal ward was admitted at the age of 24 hours with history of cyanosis. This baby was quite sick and need immediate intubation and ventilation central lines, and Postin was started because the way the patient has presented, the suspected diagnosis was having a duct-dependent cardiac lesion because the femorals were not palpable as well. And I was called to do an echo on weekend. And it's interesting to see, this is subcostal view, and you can see there is the four ventricles, yeah, and then their patient has got a significant perimembranous VSD. And if you see the next video clip, you can see that one is that's a right ventricular cavity, and a large vessel is coming out of it, and it is not dividing into two. So it's more likely an aorta coming from the right ventricle. And if you see the next clip, that's a left ventricle, yeah? And if you can see very easily and can appreciate the aorta, one vessel is coming, and then it's dividing into two. So that's quite clear that this is pulmonary trunk dividing into two. And if you see this, the next clip, you can see it's a parasternal long axis view, and the two major vessels are parallel to each other, and that's another indication of diagnosis. It is likely a TGA. So the diagnosis was TGA with perimembranous VSD. Clips were reviewed by the cardiology team, and they agreed with the diagnosis. And if we look at my audits, again, over a 5-year, the same audit, there were total 38 patients, and 32 patients were having critical congenital heart disease. And the criteria for critical congenital heart disease was that they have got, they need intervention within 1 year. And there was 6 cases of non-critical congenital heart disease. So their total 34 patients were reviewed, and 4 could not be because of various reasons. Coming to the prematurity group, usually looking at PDA, ASD, or central line positions, and then doing for assessing and treating hemodynamically significant PDA, and sometimes we do echo for evolving congenital heart disease as well. Well, I wouldn't go, I have got a less time, so I wouldn't go through this. This diagram is just showing that how we classify as a PDA as a hemodynamically significant PDA. There is evidence of pulmonary increased volume overload, and then you can see the duct of size 2 millimeter or more, and then you can see the the Doppler, the pulse, the duct Doppler, which is low velocity and pulsatile, and then you can see there is a reverse end diastolic flow in the descending aorta. So usually we use the following criteria, and there were 74 patients with PDA diagnosis, and then many of them were treated with conservative measures, and some needed about 6 patients COX inhibitors, and only 1 patient need surgical closure, and so the practice was quite according to our practice. And this diagram, this is a quite interesting case that we have a patient who is 27 weeks and 1.25 kg. Echo on day 3 was done because of a heart murmur, and then found to have mild to moderate pulmonary stenosis. And so if you see, this one is quite clear. Again, it's a subcostal view, which is just showing the right ventricular cavity, and that's a tricuspid valve, and this is the pulmonary wall, and aorta is sitting in the middle, and that's where the tricuspid valve, pulmonary valve, is stenosed, and have got a quite increased velocity as well. And this pressure gradient was gradually increasing. Initially was 41, then went up to 60s, and then it went up to 120 millimeter mercury, which was a critical pulmonary valve stenosis. So obviously patient can't be operated with the weight of 1.25 kg, stayed with us till the weight reached to 2.5 kg, and then went there, have a transcatheter pulmonary valvotomy, and that following post catheter valvotomy, patient has got a pressure gradient coming down to 50 from 120. We do use our echocardiogram skills for line positioning, where we are not sure where the lines are, or sometimes we see unexpectedly in the during the echocardiogram. And this is a baby who is ex-preterm, and this is a subcostal view, IVC, and that's draining into the right atrium, and you can see a radiopaque shadow floating in the right atrium. And in this apical view, you can see again a radiopaque shadow in the right atrium. So the line was identified in the right atrium and was pulled out accordingly. That's another diagram. I was asked to do an echocardiogram on a patient who had a heart murmur, and you can see this. Again, this is some sort of subcostal view, 4 chambers, and you can see the radiopaque shadow in the left atrium. And then in the same window, I was able to see the catheter in the PFO, going through the PFO into the left atrium. And then in the parasternal long axis view, even I don't need to play it, you can see this catheter tip is in the left atrium. So the line was identified, pulled, and managed accordingly. And the patient was having really normal cardiac anatomy. Coming to the surgical cases, I will skip my surgical cases. Almost all cases, we get baseline echocardiograms, and it's quite important in case of tracheoesophageal fistula, congenital diaphragmatic hernia, or congenital diaphragmatic hernia with critical congenital heart disease. Coming back to my audit results, so there were 258 echocardiograms were done on 233 patients. Most of the echo were done in routine working hours, but have to come sometimes out of my working hours, routine working hours. And then if you see, most of the patients were from the NICU, about 2/3, and then some in our SCABU as well, and some coming from the postnatal. At that time, sometimes we were not having service available in the ICU or in the pediatric cardiology, in the pediatric ward, and I did do some echo on that side as well. So looking at this neonatal cardiac review outcome, there were almost 2/3 patients having normal cardiac anatomy, only around 5% having a VSD, and 16.3% having a critical congenital heart disease. And in the preterm groups was only about 16%. And if we look at the outcome at discharge, in total patient were in Mafraq Hospital were 233, and really we were able to discharge 88% patients from home. and we need to shift only 17 patients to SKMC, around 7%, and some obviously died for various reasons, being very sick or not operable, 3.4%, and a couple of patients did go abroad as well. And if we see specifically for the cardiac, with the cardiac issue, 38 patients, 16 patients were discharged home, about half of the total number of patients with cardiac issues. And then about 15 patients were shifted to SKMC, again, death at Montfort Hospital, and then one went abroad as well. If we look at the outcome at SKMC, we did follow. So there were 6 patients who had a regular follow-up. 16 patients need intervention and follow-up. Some died at SKMC, around 7. One of the patients with that PDA had PDA closure and then was shifted back to us. So the audit outcome was really is that most of the cardiac diseases were diagnosed correctly, PDA has been managed properly, and really echo has got its own role in management of persistent pulmonary hypertension. And it is really safe to do echocardiogram by the neonatologists, and it really has been supported very well by the regulatory bodies in United States, in United Kingdoms, and the Europe as well. But the key message is to recognize your limitation and practice within your area, and never practice as in isolation. Always work with the regional pediatric cardiology team, and that's usually very safe practice. Thank you very much.
Thank you, Dr. Ali, for such a great talk. I still think the echo could be a friend, but I think there's always a skill in image acquisition, interpretation, and applying to clinical practice, but we can talk more about it later. Moving on to our next speaker, I'd like to introduce Dr. Heidi Herrick. Dr. Herrick is an attending neonatologist at Children's Hospital of Philadelphia, and she's an attending physician there. She's going to talk to us about the intubation safety in the neonatal ICU. So join me in welcoming Dr. Herrick.
Thank you for that introduction, and thank you again for the opportunity to speak with you. Yesterday, you heard me talk about one of the hats I wear, which is the human factors hat, and today I'll be talking about my other hat I wear, intubation safety. The title of my talk is Optimizing Neonatal Intubation Safety. I have no disclosures. The learning objectives for today's talk are to understand the safety and success profile of neonatal intubations, to discuss known factors associated with improved neonatal intubation safety, and to explore novel approaches to improve neonatal intubation safety. We're all familiar with intubation. It's commonly performed for resuscitation, for infants who need mechanical ventilation, and for surfactant administration. It is a life-saving procedure, but it can often be technically challenging and potentially dangerous. The National Emergency Airway Registry for Neonates was founded in 2014 to study the process, outcome, and safety profile for neonatal intubations. It was derived and modeled after the National Emergency Airway Registry, which was founded in 1996, and then also after NEAR for Kids, which was founded in 2010. The National Emergency Airway Registry for Neonates is also known as NEAR for Neos, which I'll use in the remainder of my talk. Since inception, it's now at 24 sites across 7 countries. We still use the acronym NEAR for NEOS national, even though it is now an international program. As part of the registry, information is gathered for each of the intubations in these 4 domains. Patient characteristics include demographics, including gestational age and weight, diagnoses, intubation indication, and difficult airway status. Setting characteristics include time and date of the intubation, the hospital setting, and also the location within the hospital, the delivery room versus the NICU. Process characteristics include provider discipline and training level, type of device, the approach used, and whether or not pre-medication were used. Outcomes include both the number of attempts and the success of each attempt, adverse events, as well as physiologic data, including oxygen saturation and heart rate data. We also capture some elements of teamwork. For this, all of this data is collected immediately after the intubation by the clinical team, and before becoming a member of NICU, you have to demonstrate 90% data compliance. This is the current landscape of the NICU. It's been around now 8.5 years, with over 15,000 intubations across 24 sites and 7 countries. In the NICU registry, there's a mean gestational age of 29 weeks, a chronological age at intubation with a mean of 2 days, and a mean birth weight of just over 1 kilo. Here you can see a distribution of the first airway provider. Neonatal fellows, as well as nurse practitioners and physician's assistant, represent the majority of first airway providers, followed by residents, attendings, and respiratory therapists. As I've mentioned before, NICU measures both safety and success outcomes. We'll first talk about safety. NICU has a comprehensive list of 20 different adverse events that they call tracheal intubation associated events, or TIAEs. They're separated into severe TIAEs and non-severe TIAEs. And here you can see what the safety profile is. 18% of intubations are complicated by any type of TIAE, and 4% of intubations are complicated by a severe TIAE. Another 42% are complicated by a severe oxygen desaturation, which is defined by a 20% decline in SpO2. This is not an all-inclusive list, but here you can see the most common adverse events for both non-severe TIAEs and severe TIAEs. The most common non-severe TIAEs are esophageal intubation with immediate recognition, main stem intubation, and bradycardia defined as less than 60 without chest compressions. The most common severe TIAEs are esophageal intubation with delayed recognition, laryngospasm, and cardiac compression for less than 1 minute. Now we're going to move on to the success profile. Using NICU's data, we see that 52% of intubations are successful on the first attempt. Another 26% are successful on the second attempt, but 22% require greater than or equal to 3 attempts for success. We also see the success rates improve with training level of the intubator. Pediatric residents have a 24% success rate on their first attempt that increases to 56% on their second attempt. Neonatal fellows are slightly better than this, 52% on their first attempt and 78% by their second attempt. Attending neonatologists have the highest success rate, 64% on their first attempt, which increases to 88% on their second attempt. Given this backdrop and this landscape of suboptimal safety and success outcomes, let's explore some of the known factors associated with safety. These include the number of attempts, the use of paralytic premedication, and the use of the video laryngoscope. Let's first talk about multiple attempts. As you can see here, multiple attempts increase the risk of severe TIAEs, any TIAE, and severe oxygen saturation. With each additional attempt, you see the risk increase for all 3 of these. We also know that the use of paralytic premedication reduces the risk. Here in this chart, you can see paralytic plus sedation versus sedation alone versus no premedication. With paralytic, 10% of intubations are complicated by any TIA versus 29 and 23%. With severe TIAs, 2% of paralytic intubations are complicated by a severe TIA versus 6 and 7%. When you adjust for patient, provider, and practice characteristics, the use of paralytic remains associated with a decreased odds of any TIAE compared to no medication. Interestingly, the use of sedation alone without paralytic is associated with an increased risk. The other known factor that can improve safety is the use of the video laryngoscope. Here you can see the video laryngoscope versus direct laryngoscopy. Any TIAs were seen in 7% of intubations with a video laryngoscope versus 23 with direct laryngoscopy. And for severe TIA, it was 2% versus 5%. Again, adjusting for patient, provider, and practice characteristics, the use of the video laryngoscope was associated with the decreased odds of any TIAE. Unfortunately, there are barriers to using these factors and to optimizing safety of intubation. The first one is the need for trainee education. Yes, we could improve safety by having the most skilled intubator intubate all the time, but that's just not feasible as we need to train the future generation of neonatologists. Additionally, we see significant variation in paralytic use across sites, and also we see significant variation in video laryngoscope use across sites, even when sites have a video laryngoscope available. With these barriers in mind, we must also pursue novel approaches to try to improve safety. I'm going to talk a little bit more about 3 of these approaches that I'm actively pursuing. The first one is an individualized airway bundle. The second is the use of apneic oxygenation, and the third is a human factors approach. Let's first talk about the airway bundle. You've heard me say this a few times, but neonatal intubation safety and success outcomes are unacceptable. With this in mind, we developed a quality improvement project to address neonatal intubation safety at the Children's Hospital of Philadelphia. Our SMART aim was to reduce TIAEs, or adverse events, by 10% over 12 months. We did this through developing a prospective, individualized airway bundle to increase the adoption of evidence-based interventions and to improve team communication to create a shared mental model by all providers on the team. This included respiratory therapists, nurses, the primary medical team, as well as the covering medical team on nights and weekends. We devised the airway bundle to address the 4 primary drivers for TIAEs that we decided upon as an interdisciplinary team. These were risk assessment, team preparation, including the emphasis on the use of video laryngoscope, pre-medication, and team communication. The bundle was developed to specifically address each of these, and now I'll show you how each of these were addressed. Risk assessment was initially just identifying patients that were at risk for intubation. If they were identified as being at risk, they required an airway bundle to be hung at the bedside. Risk assessment also included evaluating if the patient had any risk factors for difficult intubation or any difficulty with bag mask ventilation. Team preparation included describing how and when the team should intubate. This included type of device, again emphasizing the use of video laryngoscope, the size of the NT tube, and the approach. This also included a plan for an unplanned extubation. Should the team immediately reintubate, or should they trial the patient on non-invasive modality? Pre-medication was included as part of team preparation. For this project, we developed a pre-medication order set within our electronic medical record that included atropine, fentanyl, and vecuronium. We encouraged the team to order these medications as on-call PRN to try to reduce any delays in either getting the medication or administering the medication. We also asked the team to indicate if there were any contraindications to pre-medication, and if there were, not to order them. The entire airway bundle looked at team communication, but the backside of the bundle was specifically designed for use immediately before the intubation. We developed a timeout as well as a short post-intubation debrief that consisted of 2 questions. Here you can see a control chart showing the rate of severe TIAEs by month. We created the airway bundle in September of 2017 and rolled it out to the entire unit in April of 2018. Through the introduction of the airway bundle, we were able to achieve a 66% reduction in severe TIAEs from a baseline of 0.047 per intubation encounter to our current rate of 0.016 per tracheal intubation encounter, and we've maintained this for over 3 years. I haven't had a chance to update this graph, but we're still at this rate today. We also were able to achieve a reduction of overall TIAEs by 44% from a baseline of 0.093 per tracheal intubation encounter to our current rate of 0.052 per tracheal intubation encounter. One of my colleagues and mentor, Elizabeth Foglia, recently received funding for an R01 from the NIH to look at the impact of the airway bundle across multiple sites. This is called Option SAFE, or Optimizing Tracheal Intubation Outcomes for Neonatal Safety. It's a step-wedge randomized trial that will be conducted at 8 near-Frenio sites. All sites will receive the bundle intervention, but the timing of the bundle introduction will be randomized, as you can see in this schema here. The pre-intubation phase will be compared to the post-intubation phase at all sites. The specific aims for this trial are to determine the effectiveness of a personalized intubation safety bundle, the PINS bundle, to decrease adverse tracheal intubation events. The primary outcome is all tracheal intubation adverse events. The second aim is to evaluate the impact if there is an impact of the PINS bundle on adverse tracheal safety events, if this varies by provider skill level, looking specifically if there's a bigger impact on trainees than more seasoned intubators. And then the third aim is exploratory, to determine the impact on the PINS bundle on NICU clinical outcomes, including extubation failure, duration of intubation, NICU mortality, and for preterm infants, rates of IVH. The next avenue that I'm actively pursuing is studying apneic oxygenation, or the application of free-flowing oxygen during laryngoscopy, which has been shown to reduce or prevent desaturation in adults and pediatric patients during intubation. There's some emerging literature that this may be beneficial for neonates as well. I'm currently running a randomized control trial at the Children's Hospital of Philadelphia and at the Hospital of the University of Pennsylvania entitled the POINT trial, which is providing oxygen during intubation in the NICU trial. In this, we'll have 110 patients that are undergoing intubation in the NICU. The intervention is apneic oxygenation during laryngoscopy versus no support during laryngoscopy, with the primary outcome of the magnitude of desaturation during the intubation encounter. For this trial, we define apneic oxygenation as 6 liters regular flow nasal cannula, 100%, and all patients must receive paralytic pre-medication to be part of this trial. You may have recently heard about the SHINE trial, which came out in 2022, which looked at procedural oxygenation during intubation. I make the distinction here of procedural oxygenation versus apneic oxygenation because pre-medication was not a requirement in their study. In this study, they looked at neonatal patients undergoing intubation, and the intervention was high flow nasal cannula during laryngoscopy versus no additional support during laryngoscopy. And their primary outcome was first attempt success without physiologic deterioration, which they defined as a heart rate less than 100 or a decline in SpO2 by greater than 20%. And this was during the intubation. For their primary outcome, they saw in the intervention group, they had 50% success without physiologic deterioration on the first attempt versus 31.5 in the control group. I want to emphasize a couple of the key differences in our study. In the SHINE trial, again, it's procedural oxygenation, as pre-medication was not mandatory. They had actually low video laryngoscope use, and their intervention was 8 liters high flow nasal cannula with variable FiO2. For the POINT trial, we're looking specifically at apneic oxygenation, where pre-medication is mandatory. We have a high use of video laryngoscope use at both of the hospitals where this will take place, and our intervention is 6 liters regular nasal cannula at 100%. Many of the other aspects of the protocol and outcomes were harmonized intentionally for an upcoming meta-analysis once our study is complete. This slide here really just shows you that there are multiple approaches to improve safety. In this, you can see the percent of patients that had successful intubation on the first attempt without physiologic deterioration as defined by the SHINE trial. On the left, you can see the results of the SHINE trial using procedural oxygenation. In the control group, it was 31.5, and in the intervention group, it was 50%. On the right, you can see our current CHOP data. We have very high use of video laryngoscope at 96% for our intubations, and we have high use of paralytic at 91%. Here you can see that our baseline data is relatively similar to their intervention group in the SHINE trial. We're excited to see what the outcomes will be of the POINT trial, but we do wonder if we'll be able to improve from this baseline data, but we're excited to see what that outcome will be. And the last way that I'm pursuing trying to improve intubation safety is through a human factors evaluation of intubation. I'm actively working with collaborators in Australia as part of the THRIVE trial to look at flow disruptions during tracheal intubation for both pediatric patients and neonatal patients. And here you can see a conceptual model of a potential proposed grant in the future, not sure yet, looking specifically how flow disruptions impact patient outcomes during tracheal intubation, and also looking how flow disruptors impact providers as well. In a preliminary analysis, I found that neonatal intubation flow disruptions are incredibly common, and they are actually quite stereotyped. We found a mean of 16.1 flow disruptions per tracheal intubation attempt, and we found that equipment, design, and usability flow disruptions were the most common type of flow disruptions. In addition to just the frequency, we saw a pattern that emerged. Most of the flow disruptions started with a coordination flow disruption that was followed by an equipment flow disruption. The most common coordination flow disruptions were about confusion and delays about who would apply cricoid or who would pass the endotracheal tube to the airway provider. The most common equipment flow disruptions often revolved around the stylet, specifically the positioning of the stylet, the curve of the stylet, and difficulty with removal. While this is just a preliminary analysis, it does show some potential targets for improving intubation efficiency, and hopefully with a larger trial, we'll be able to see if it actually can improve, addressing these can improve intubation safety. As I mentioned before, we think that there's multiple ways to improve neonatal tracheal intubation, and we really see these things as a toolkit that people can use at their institutions depending on availability and acceptability of these different things. Proven approaches are video laryngoscope and paralytic pre-medication, and some emerging approaches that have some promise are procedural or apneic oxygenation and the airway bundle. So in conclusion, adverse events are common, but you have to look for them, and I would stress to consider systematically tracking intubation outcomes. It is possible to improve intubation safety through the use of paralytic pre-medication, video laryngoscope, and potentially through the use of an airway bundle, and potentially through the use of procedural or apneic oxygenation. And with that, I'd like to thank you.
We're on the home drive now on this session. And we are going to have an earlier speaker make a second advent. That is Dr. Matthew Gillespie, who is an attending cardiologist in the Cardiac Center and a medical director for their cardiac catheterization program at the Children's Hospital of Philadelphia. Matthew spoke to us earlier on about catheter closure of PDA. He will be talking to us again now, virtually, on a topic titled, Update on Catheter Procedures for Congenital Heart Diseases. You're going to put it on now? Okay, thank you.
Hello again, this is Matt Gillespie from the CHOP Cath Lab. I was asked to give a talk on an update on catheter-based therapies for congenital heart disease. This is obviously a topic that's near and dear to my heart. I'll say up front that there will be very little data presented in this talk. And I'll also say that a lot of this is not necessarily germane to newborn infants and the NICU, unless you consider the fact that you're trying to get all your patients to grow into childhood and adulthood, in which case some of it might be interesting to you. Either way, let's just move forward with the talk. These are my disclosures. So it might not be a surprise to anybody that I see the Cath Lab really as the center of the cardiology universe. And there have been major advances in catheter-based therapy over the last 25 to 30 years, and a lot of them are just now beginning to touch the world of congenital heart disease, and a lot of this is spilling over into our newborn babies as well. Broadly speaking, I would break the sort of update and the innovations in catheter-based therapy into three broad categories. One would be heart valve therapies, Two would be newer closure therapies that have come along the line, and three would be palliative therapies. And we'll just touch on some of these broadly. First, let's start with valve therapies, because I think this has probably been where the most activity has happened over the last 10 years in terms of therapies available for patients with both adult structural heart disease and congenital heart disease. And TPVR is an acronym for transcatheter pulmonary valve replacement. And it's no surprise to anybody that anomalies of the RVOT represent about fully a quarter of the patients that we deal with in congenital cardiology. And a lot of them have had successful repair in infancy of things like tetralogy of flow and truncus arteriosus. And what they're left with is a dysfunctional right ventricular outflow tract. And over the years, there have been therapies that have been designed to treat dysfunctional surgical RVDPA conduits, things like the balloon expandable melody valve there on the right and the balloon expandable Edwards sapien valve on the left. What's happened in recent years is not only the balloon expandable platforms for stenotic lesions, but patients who have chronic pulmonary valve regurgitation, there's new therapies that are coming online for them. Here's an example of what two balloon expandable platforms would look like when implanted into the pulmonary position. But broadly, when you're treating pulmonary regurgitation as the primary target lesion that you're trying to fix, the balloon expandable platforms have been too small. They're just not big enough for children and young adults with chronic pulmonary valve regurgitation. And this is what a typical RV outflow tract looks like. It can sometimes be 3 or 4 centimeters in diameter, which is really pretty massive and too big for the existing balloon expandable platforms. So it's also the RV outflow tracts of these patients who've had successful surgery but are left with pulmonary regurgitation tend to be very dynamic. So when you're trying to implant a valve in these patients, the valve has to be able to accommodate the dynamic environment that you're implanting it into. And again, this is important because from your standpoint, because when you have infants in the NICU with congenital heart disease and you hear that they're going for tetralogy of flow repair, successful repair is going to leave them typically with chronic pulmonary regurgitation that we're going to need to deal with down the line. And the answer to this is a self-expanding platform, and early ideas were hatched in 2004 with the early development of self-expanding platforms. This led to a first implant of a prototype in 2009 at Great Ormond Street, and since then there has been a recent explosion in technology, including the Medtronic Harmony valve, which is available and now in 2 sizes. On the right there, that's the Edwards sapien valve with the Altera pre-stent. And around the world, there are 3 others that have made it into commercial use. In the United States, the Harmony TPV 22 and 25 are the most common. And this is what that looks like if you want to see a procedure. What you're looking at there is an angiogram with a catheter in the pulmonary artery showing that there's severe regurgitation. And what you're able to do is run the Harmony system up over a stiff guide wire into position. These systems are made to be self-expanding so they can compress down into reasonable size delivery catheters. And once you get it into position, you can uncover it. It'll blossom into position. And what you have is, voila, you now have a competent pulmonary valve where once you had free pulmonary regurgitation. There's other answers to this, including the Edwards Altera system, which is a 2-step process where you implant a self-expanding frame to fill the dilated MPA, and then into that place a balloon expandable valve. This is what that looks like after implant. And around the world, there have been others, including the Venus P valve, the MedZenith PT valve, and the Pulsed valves. So as far as update goes in valve replacement therapy, we now have a plethora of devices that have come online in recent years. Are really going to alter the quality of life and I think the duration of life. A lot of the patients that we're treating in infancy who have abnormalities of the right ventricular outflow tract, including tetralogy of flow. So just to skip through that. So the goal for all these therapies is to get these babies out of the NICU and out of the cardiac ICU and to get them to be grumpy old men like me and beyond. I think these therapies are going to be able to facilitate that, and to try to get them there with the least amount of open heart surgery as possible over time. Well, there's other valve therapies that are coming online. This is an example of a single ventricle patient who has severe systemic tricuspid valve regurgitation. And again, there are therapies that have come online that allow us to now address this non-surgically. And here at CHOP, it's just another echo image showing the same. We have access to one of the therapies that's being used in the adult structural world here at CHOP, called the MitraClip. And this is an example of a patient. You don't even need to understand echo to see that this red angry flame blowing back at you is severe tricuspid regurgitation in a Fontan patient. And what we're able to do is using these systems that are not necessarily designed for single ventricle patients, we're able to cross into the atrial chamber through the Fontan pathway, and then go ahead and place a clip on the regurgitant areas of the valve. And in the end, as we become technically more proficient at this, we're able to clip these valves and improve their coaptation. So on the left there, again, you can see the pre-procedure amount of regurgitation. And now on the right, you can see that it's much better. And what this means is a higher quality of life for our single ventricle population without having to send them to repeat surgery. So a real exciting update. This is progressing in the adult world to the fact that to allow replacement of tricuspid and mitral valves in a non-surgical way. Here's a couple of examples of devices in the position there. And here's an example of a research device that we were working on at Penn and CHOP as far back as 2009. So the point is that all the advances in catheter-based therapy are making management of valve dysfunction even more possible with less invasive approaches. And all of this, I think, is going to have an impact on our congenital heart disease patients, a lot of them that start with you in the NICU. So what about closure therapies? In my earlier talk, I would say the biggest advancement in closure therapies that we're seeing that's impacting the NICU is the PRIMI-based PDA closure. And we've already gone through this. I've already explained to you all that I felt like I was one of these Japanese soldiers who was found in 1974 on an island still fighting a war that didn't exist, meaning that the NICU neonatology community walked away from being aggressive about PDA closure at a time when the interventional community was really fighting hard to find solutions for PDA closure in infants. I think we're starting to come together now. As I mentioned in my other talk, we talked about the Piccolo device, which is now approved. And again, here's a 900-gram X24-week preemie, and this is what the Piccolo procedure looks like. Again, close the PDA, no obstruction to the branch PAs, no obstruction to the aorta, as you see here on the echo. And it really has changed. I think it's changing the equation on how best to manage those patients. And, that debate is going to ensue. And I think we're in for some interesting times when it comes to consideration for how best to manage these large PDAs and these small babies. All right, what about the third broad group of new innovations or updates in catheter-based therapy? Well, I would broadly categorize these as palliative therapies, and this really touches the NICU pretty dramatically. And probably the two areas that most frequently impact patients in the NICU and patients in the cardiac ICU would be in patients where we're palliatively stenting the ductus arteriosus, either to augment systemic blood flow or to augment pulmonary blood flow. There's all the other procedures that we perform regularly in newborns and patients in the NICU will be pulmonary vein dilation and balloon valvuloplasty, and oftentimes we have to stent the atrial septum to keep the atrial septum open. So why and when do we stent the ductus arteriosus? Well, essentially there's some lesions like hypoplastic left heart syndrome or hypoplastic left heart syndrome variants where it's necessary to stent the ductus arteriosus to augment pulmonary blood flow. to augment systemic blood flow. And it's also the same patients who have ductal-dependent pulmonary blood flow, such as pulmonary atresia with intact ventricular septum, tetralogy of flow with pulmonary atresia, where it's necessary to keep the ductus open to provide flow into the lungs while we anticipate definitive surgical repair later. This is what that looks like if you're going to do a hybrid Norwood operation. You want it to mimic the surgical Norwood procedure. You're all familiar with the surgical Norwood procedure. Well, the goal of the surgical stage 1 is to have an unobstructed systemic output, restricted pulmonary blood flow, and an unobstructed venous return. And it's the same goal when you're doing this in the cath lab, using a combination of surgery and ductal stenting to hold open the ductus. You can also perform this procedure now completely percutaneously by using pulmonary flow restrictors, which we modify in the cath lab and allows us, instead of putting surgical pulmonary arterial bands on, allows us to restrict flow to the branch pulmonary arteries by putting plugs into the PAs at the same time that we stent the ductus arteriosus. There are some theoretical advantages and disadvantages, but this is the goal that you're after. And in the cath lab, what we would do is put the stent in the duct to keep it open, which would allow the baby to grow in anticipation of the second stage Norwood surgery. And again, these PA bands, as shown here and here, can be placed either surgically, or nowadays we're doing more and more of it in the cath lab with flow restrictors. And all of this is done with X-ray guidance and often echo guidance in collaboration with our surgeons. This is what this looks like. Here's a typical example of a baby born with a borderline left ventricle. The first procedure would be stenting of the atrial septum. So we do a transeptal puncture there, blow a balloon up across the atrial septum to stent that septum. And afterwards, what you see is the stent is in good position and it's unobstructed. Then the next stage would be if you're going to restrict pulmonary blood flow with surgical PA bands, you would do a median sternotomy, tie those bands on, which you can see both on the right pulmonary artery right here and the left pulmonary artery right here. There's flow restrictors wrapped around the outside of the PA. And then your job, the next step is to maintain ductal patency here by implanting a self-expanding stent is the one that we prefer to use a CHOP. You can always also do this with a balloon expandable stent. So in this way, you've created a situation where from the right ventricle, blood can flow in an unobstructed way across the ductal arch into the descending aorta, and the flow is limited to the branch pulmonary arteries by the pulmonary arterial bands. And this is what that looks like here. Just to show it again, on the left is the stent going in, and on the right is the ductal stent after it's implanted with an unobstructed ductus arteriosus. The outcomes have basically been shown to be equivalent in the hybrid versus Norwood stage 1 era. This is an evolving procedure that is going to involve more and more of this being accomplished in the cath lab, as we said earlier. Well, you can also stent the duct to ensure pulmonary blood flow. Here's an example of a patient with pulmonary atresia with intact ventricular septum. And you'll see when you inject into the subpulmonary area, there's really no antegrade flow across there. So what we would typically do is cross that with a radiofrequency perforation wire and then dilate the annulus. And then oftentimes it's necessary to stent the ductus arteriosus to allow time for the right ventricle to improve in compliance and to move into a more standard two-ventricle situation. And this is just a picture there showing the patient who had the pulmonary valvuloplasty followed by the ductal stent procedure. You can also stent the duct, and this has become our preferred route in a lot of patients by way of left carotid access. You can percutaneously stick the left carotid, and typically it puts the catheter right at the arch of the ductus arteriosus. And then there it is there. And it's just a matter of walking the wire through, deploying the stent. That's one stent in here. This is the second stent being deployed there. Like that. And then afterwards, you can see when you inject down from the aorta, there's unobstructed blood flow to both the right and left pulmonary arteries. So we're doing more and more palliative ductal stenting now in patients with pulmonary atresia who don't have another source of pulmonary blood flow. and that this is happening really instead of surgical BT shunt placement, blade octosity shunt placement. And we're finding that this is something that patients recover from very quickly, and you can push off their definitive surgical repair until they're older and from a neurological standpoint and otherwise more mature, and we think that's going to lead them to tolerate the definitive surgical repair better. So again, we have these palliative therapies in addition to all these other advancements. The other thing that we often will do nowadays, and you'll see in your patients with BPD, we often have the association of pulmonary vein stenosis. Here's an example of a patient with severe pulmonary vein stenosis being stented by one of my colleagues here. And in the end, you can see there is much improved flow out of that right upper lobe. So therapy for pulmonary vein disease has really advanced in recent years to the point where we have multiple different stents available to us, mostly using embedded drug-coated stents to try to minimize neointimal proliferation, and this in combination with systemic antimetabolites is really leading to a much rosier outlook for these patients than what we even had 10 years ago. So in summary, catheter-based therapies continue to advance. I think it's really one of the more exciting places in medicine to be right now. We have emerging valve therapies. We have newer and safer closure therapies, I think best demonstrated by premium PDA closure right now. There's also bioabsorbable technology that I really don't have time to get into now. And then we have these evolving palliative strategies that are really improving the health of infants and newborns born with congenital heart disease and things like pulmonary vein stenosis. So with that was a whirlwind tour through cardiac catheterization and therapy for congenital heart disease. I hope you found it interesting, even though a lot of this might not be applicable now. The goal is to get these patients to grow to a point where maybe we'll be able to help them in addition to what you've done for them early in their life. Thank you so much for the opportunity to participate here. I look forward to seeing you all in person sometime soon. Thanks.
All right, that was a wide array of topics of procedures in the NICU. I would like to invite the speakers in the previous session to come onto the podium for the question, answer, and discussions. Dr. Junaid.
Thank you very much. Again, brainstorming type of a session. So my question, I'm not good in the cardiology, but my question to Heidi about everyday thing, the intubation safety. So as you know, intubation in many of the places, including ours, are not in a very, calm environment. It is most of the time is panicking, very haphazard, this thing. So how you suggest to improve on that first, and is there any limit of that one person can do the intubation that much time and then just leave the baby, somebody else try, or bring the baby in a safe environment and do that?
You raise, is this the son? Yeah, I think you raise a great question, and I think that one of the big things is you have to really understand the environment in which the intubation is happening. I actually looked at intubations in the delivery room versus NICU to look at sort of practice variation between that, and almost everything was different between them. The type of equipment people were using, the type of babies they were intubating, who was doing the intubation. And so I think the first thing to do when you're thinking about intubation safety is to really evaluate the location where it's happening. So our airway bundle and things that we did were within the CHOP NICU and what made sense there and what we had access to. And that was specifically for the NICU, not the delivery room, where the delivery room often is a little bit more chaotic, a little bit more panicking. And so I think that Not all of these things are going to be applicable to every site, and that's why I really think about it as sort of a safety toolkit, and you really have to look at what is accessible at your site and also what's acceptable, because a lot of people will say, absolutely not, I'm not going to do a paralytic in a VLBW, there's no way. Some people will say, let's not use video laryngoscope because I don't want to lose my skill. And so in those situations, potentially the procedural oxygenation would be a better way of doing it, or sort of also just looking at sort of the typical sort of, not hiccups, but the things that are sort of blocking you from performing a smooth intubation. Maybe it be where the equipment is in the room, little things like that I think can improve that. And then your second question had to do with the number of intubation attempts. Where I practice, we limit it to 2 attempts per provider. So you get 2 attempts and then it goes to the next one. And that's really up to the discretion of the person that's leading it though. So if I'm watching and it's a fellow and on the first attempt, they're not even close to getting anything, I might say, okay, we're gonna go to the next person rather than letting them sort of almost fish around to try to find it again. But usually it's 2 attempts and then it goes to the next provider. Yeah.
Go ahead.
My first question to Dr. Matthew, is he still around? Dr. Matthew, is he still?
He's not available online, so his questions to him will be deferred.
Okay. Then my next question to Natalie. I mean, the ethical question about dealing with the renal agenesis, and then it's massive ethical question, because there are multiple levels to it. Now, how you deal with that questions among your colleagues, but also with the family, and then third level maybe with the regulators, the one who wanted to have chair in the regulatory bodies. One, you have a child or children maybe coming and taking a lot of resources from the society. So how do you deal with this kind of equal distribution of resources among the community that you're serving? I mean, this question maybe you face with the family, you face it with your colleagues, but also from the regulators who may be pushing you to do these procedures where you are thinking about what to do with the rest.
Well, yeah, it's really complicated, and it just happened after they shut that arm down. So we were hoping that we would be able to figure this out. And now we're struggling a bit because medicine in the US is quite regional. It's different state to state. So there are a lot of places where maternal fetal medicine, they're proceeding with these amnio infusions. They're not even part of a fetal team or even a pediatric center. So we're really struggling with the downstream consequences right now. We even had a big meeting at our hospital. Do we accept these patients in transport? If they deliver at an outside hospital and then they need dialysis, should we accept them if we've shut down that arm of the trial within our own children's hospital? So it is fraught with ethical problems right now. Agree with what you're saying. Does that answer your question?
How do you deal with it? I mean, at the moment, I mean, there are multiple levels. One with your colleagues. Your colleagues, I meant with the obstetrician or the fetal medicine, because they wanted to do procedures, and then they end there, and then eventually it will come to you.
So we've decided to respect the trial. So in our own fetal center, we're not doing amnio infusions for renal agenesis right now. If we receive a transport call from an outside hospital where a baby is in room air or cannula and they've had this procedure and they need to come for dialysis, we will accept them. So then our responsibility is to the baby. But we're not doing the amnio infusions ourselves right now.
We'll move on to the next question, Dr. Faisal.
Thank you. This question really for Natalie. When you talked about the fetal and tracheal exclusion for especially left CDH, so my question is that you talked about reduction, need for ECMO, and you talked, I think, discharge also. What about long-term outcomes, especially the neurodevelopmental babies. That's really one thing. And the second question is that, what about the ethical issue? If parents come in and it's not an isolated left CDH, there is other abnormalities, will you still offer the fetal if they request it?
No, those are great questions. And so right now, all patients are followed up in our pulmonary hypoplasia program. So we have a large program. We have over 800 CDH patients in that program, and we follow them really closely. Now, the feto kids are still relatively young, but early on, they seem to be doing very well. We did have one baby where it was difficult to get the balloon out. There's some neurologic differences with that little one, but he's still relatively young. But we follow them very closely. So far they seem, for the most part, they seem to be doing well. 9 out of 10 are doing well. And then the second question is, will we accept kids with other anomalies? And right now that's no. They have to be isolated left CDH. So they all have genetic testing, pre-cardiac workup. So no, just isolated.
Yeah, my question to Dr. Syed, you're doing excellent job doing the ecos, but my question about the law here, how much, because I saw many of your slides where you said you diagnose like congenital heart diseases. So are we allowed as a neonatologist to do that, or we have to have our first echo done by a pediatric cardiologist on that? Because, medical legally, how safe we are to, give these kind of echo diagnosis?
Well, still the rules are not clearly defined here in UAE, but in states, in United Kingdoms and in Europe, they have published the recommendations for training and practice, being neonatologists and practicing echocardiogram as well. But what I do, and possibly that came up, which I haven't seen in most of the people doing it, that whatever I do, I record it and I share it with my cardiology colleague most of the times. And then if the patient has got a significant congenital heart disease, I make a diagnosis and then I refer the echocardiograms to the cardiologist and they review it, they agree or disagree, whatever they see. Obviously, they are the experts, so I don't practice as a cardiologist, but I do practice echocardiograms, and the way I have been trained is can make the diagnosis. But remember that I'm not a cardiologist, so there is a situation when I'm not able to make the final diagnosis, but I describe what I see, and I immediately refer my echo images. So I think the important thing is not to work in isolation, and have a proper, know your limitation and work according to that. And second thing is, I do have privileges of doing echocardiogram according to my hospital rules and regulations. So they have given me privilege. So
functional echo is done by across the globe, but to diagnose the structural lesions, that was my question. Functional echo, all of us are doing.
You're absolutely right, but it depends on the center where you're working and what resources they have got. If you're working in a tertiary level unit, for example, in Sidra Hospital, they have a practice in a neonatal unit that the first scan is done by the cardiologist. He rules out all the congenital heart disease, and then the functional echo can be done by the neonatologist. But in my hospital or in many other hospitals, I assume not each hospital has got a pediatric cardiologist. So in those hospitals, it's the need of the patient, which you can help if you have the skills. If not, then you can build it up. But again, work in a team, not in isolation, and always get peer review.
Thank you. Thank
Just to add to that, like you said, Ali, we also have privileges, an established pathway recognized internationally regarding the skill set for a neonatologist to be given a privilege to do those echoes. But like you said, the hallmark is that you need to know your limitation and you don't work in silo. You need to have somebody to peer review what you're doing in order to be safe.
That's the bottom line. Have a peer review.
I just have a question for Natalie, if you don't mind. A few months ago, in our own local exit and fetal program, we delivered our first baby 2-3 months ago, who has gone on to do well. But I just wanted to know, how do you manage the stress of it? Because once that balloon goes in, everybody in the team is worried. This lady can come in at any time. And no matter your guidelines about the teams who will be present, ENT, the FMU specialist and all whatnot, you want to get that tube out. Because if you don't, you have a baby with a closed airway. So you have been running this program for some time. How do you manage that? The stress around such babies who have been put into this program.
The stress while they're in utero or when they're out? Like it's
Yes.
it's so stressful,
Yes.
right? So I mean, once the balloon goes in, the whole hospital knows that a balloon is in, and our maternal fetal medicine, ENT, the surgical colleagues, the neonatologists, we're all on call for the entire time, so we know. So we have like a special feto super secret backup group. So let's say Heidi's on call for special delivery unit. So we have an in-house attending covering the NICU. Then we have an extra attending on call for special delivery. And then if that mom is coming in with the balloon, even if she's not in labor or we don't know for sure, then like Heidi would call myself or one of 2 other colleagues, and we would all come in. ENT would drive in, Holly Hedrick would drive in, like, 10, 15 of us show up. And then they say, oh no, she's fine, she's going home. And then we all drive home. So it's like a month of our lives where we are all on call for that entire time. And even Holly Hedrick, she won't travel during that time. I may have mentioned that, like if she has plans and everything goes off. So it's all in. We're very committed to that. When the baby, delivers and there's an impending delivery and the balloon is still in, it's very stressful. So we are trying to deliver and get it out prior to clamping the cord. Have we had situations where we think it's out? This is that one baby I'm talking about. We think it's out. Is it out? The lungs are totally whited out. Is it secretions? We've got ENT. We're lavaging with surfactant. They can be very difficult, very, very difficult. So it is very stressful. We debrief afterwards.
And we've used video view after to improve the process around it.
Yeah, but every baby is the same stress, and we have those critical knowledge screens to go over every detail. And then we have another delivery and we learn one more thing, or we see one thing that we could do better, then we change up the screens. So it is, I don't know if that helps, but it is very stressful every single time. And the whole team is all in. They're tough cases. That's why I'm so excited about this smart balloon. If she could just walk around the MRI scanner, oh my God, we'd be so happy. That'll make things a lot easier.
There are definitely more questions to be asked. We're going to hold off questions for now. It's because we're going to go for lunch. But we'll reconvene and hopefully have more questions in the afternoon. I'm sorry. But there are definitely more questions I want to ask you as well, but we'll defer them till after today. So we will break for lunch and then reconvene at 2:30. 2:30 in 1 hour. Thank you. Do I?
For our speakers and moderators, just a reminder, lunch area will be at Verso Restaurant and ground floor, and for delegates, it will be in Saha Restaurant at B2 level. See you after an hour.